Okay, thank you so much. A very good morning from Bahrain. I believe we are in the same time zone as Athens. Some of you may be attending the meeting in person. So I thought I'll start the session just to warm up with a question which is in front of the screen. And the question is, which anti-diabetic group of medications has shown the best cardiovascular outcome? And the options are 7. Is it metformin, sulfonylureas, acarbose, glitazones, DPP-4 inhibitors, SGLT2 inhibitors, or GLP-1 agonists? So I don't want you to short out an answer. Maybe if we have some time, we can discuss this in the question answer session. So the objectives of my talk are only 2. I'm going to discuss about the diabetes and the associated cardiovascular disease risk. And mainly I'm going to focus on the GLP-1 agonists, which is one of the group of anti-diabetic medications. And let's see and I'll explore what the role of GLP agonists are in reducing cardiovascular events. So we all know that diabetes has got a high global prevalence, and it does lead to a number of microvascular and macrovascular complications. And if you look at the major cardiovascular disease, which includes stroke, myocardial infarction, peripheral vascular disease, they lead to the highest number of hospitalization. And we also know that 2/3 of the patients of type 2 diabetes mellitus die due to cardiovascular disease. So they do cause a lot of heart attacks, they do cause a lot of strokes and peripheral vascular disease, and they are a cause for mortality for cardiovascular causes as well. So just to give you some numbers, so these are from the US diabetes patient database. So diabetes does increase the risk of heart diseases by 2 to 3-fold, and there's 60% chance higher of the patients of diabetes dying from heart diseases. And if you look at some more numbers, sorry for the slide which is not very clear, it's a bit blurred. So diabetes does increase the risk of cardiovascular disease. There's increase of 7% risk of stroke, 11% risk of heart attacks, and 7% risk of heart failure. Just a snapshot of the pathways how cardiovascular risk is increased in patients of diabetes. We all know that diabetes has got some predisposing factors. This is mainly a combination of physical inactivity, poor diet, smoking, and obesity. So obesity is the main player here that ultimately leads to metabolic syndrome, and one of them is type 2 diabetes mellitus. Once you have on board the other comorbidities such as dyslipidemia, other metabolic dysfunction, including CKD, there is hypercoagulable state of the platelet activation, environmental pollutants, and they all lead to pathophysiological changes such as dysfunction of the endothelial lining. There is arterial stiffness, there's inflammation, and there's also oxidative stress. So putting everything together, they all lead to abnormalities or structural changes in the cardiovascular disease, in cardiovascular system, and that will lead to cardiovascular disease and also lead to increased cardiovascular mortality. We have had a number of anti-diabetic drugs for a long time, including with metformin, which is the traditional anti-diabetic we are still using as a first-line medication. But it was realized somewhere in 2008 that there were patients who did not do well when they were put on certain anti-diabetic medications. So it was in 2008 that FDA laid down a guideline or a rule, you can say, that any new anti-diabetic drug in the medication, they must prove that they are safe to use. And so subsequently, these drugs, they had to go under trial once they were introduced in the market. And as you can see here, 2 medications you will recognize, rosiglitazone and saxagliptin, they were soon withdrawn from the market because both of them, they increase the risk of heart failure. And since then, it has become extremely important that the safety of the anti-diabetic medications, they are looked at. So we know that the anti-diabetic medication, they were first started for one reason and one benefit, to lower the blood sugar and improve the glycemic control. But later, these medications also gained popularity in terms of them having to reduce weight, particularly the newer anti-diabetic medication, which are the GLP-1 agonists and SGLT2 inhibitor also to some extent, they do help in reducing the body weight. But what was interesting is that a number of trials were done. These were the safety trials to look at if the anti-diabetic medication, they were safe. But what we found in the trials, and I'll discuss few of trials, that they actually not only showed that these anti-diabetic medications were safe, but they also had a positive cardiovascular outcome, which means that they helped to reduce the risk and events of myocardial infarction and stroke, as well as cardiovascular death, and also hospitalization for heart failure. So now it has become quite apparent that when we use anti-diabetic medications, we should look at their tolerance. We also look at their efficacy, and we also look at their safety. But above that, we are also looking at where and which anti-diabetic medications will lead to better cardiovascular outcome, will prevent heart attack, will prevent stroke and heart failure, hospitalization, and also cardiovascular death. So mainly I'm going to focus for the rest of my talk on the GLP-1 agonists. This is not a new medication, but it is, you can say, a new kid in town, and a lot of research is being done around this molecule or medication. And so the SGLT2 inhibitors, which has been there for quite some time, GLP-1 receptor agonist is recent. And these are the two medications that have really shown that they have better cardiovascular outcome. SGLT2 inhibitor has got a greater role in heart failure compared to GLP-1. And in terms of reducing the cardiovascular outcome, myocardial infarction and stroke, I would say SGLT2 inhibitor and GLP-1 receptor agonists are almost similar. So again, looking at the GLP-1 agonist, they do help to reduce weight. So they have become very popular in patients who want to achieve a normal body weight if they want to shed a number of kilograms, irrespective of whether they have diabetes or not. So some of the GLP-1 agonists, some of you may know that they are primarily being used for weight reduction and in obesity, and they may or may not have diabetes. They do help to reduce to some extent blood pressure. They help your glucose levels. They also improve your lipid profile, and they also reduce your risk of myocardial infarction, stroke, and death. This is a major adverse cardiovascular events, and improve symptoms of heart failure. So what is the pathophysiology? I put a very simple slide here. So these are incretin-based medication, GLP-1 and GIP-1. They essentially lead to stimulation of insulin. So there's increase in the insulin level, and they inhibit the glucagon release. And both combined together, they help to lower the glucose level and the associated benefit that you get with the glycemic control. And the mechanism of action in, again, a very, very simple diagram, as you can see here. It works on three areas, basically. It works on brain, and it increases the satiety. You have this fullness, and it leads to a decrease in appetite. So if you are given food, then you will not feel much hungry or will not have the pleasure for food anymore. The gastric motility is decreased, and the gastric emptying is also decreased, which means that the food stays in your stomach for a longer time. You feel full for a longer time, and again, you're going to eat less. It does have a role on the pancreas. It increases the insulin level, as said earlier, and it decreases the glucagon level, and they both help to reduce the blood sugar levels. But the question is, how does it actually help to improve the cardiovascular health? So we all know that it reduces LDL cholesterol, it leads to plaque stabilization, and therefore it is considered as an anti-atherogenic agent. It increases the nitric oxide, decreases blood pressure, and once the nitric oxide is increased, so it does help in the endothelial function. It has got some anti-inflammatory property, which has been seen from a reduction of C-reactive protein, which is a marker of inflammation. And obviously, it has become a very popular drug for weight reduction. It leads to body weight reduction, it leads to fat reduction, and of course, overall improves the metabolic health. So putting everything together does become a pathogenesis that leads to a greater cardiovascular outcome and better cardiovascular health. Now, it has also been studied. Again, a lot of research is going on with GLP-1 agonists as to whether it is beneficial in heart failure or not. And these are some of the proposed mechanisms. We do not know the exact mechanism how GLP-1 agonists work for heart failure. Now, it has got a limited role on heart failure with preserved ejection fraction, where the left ventricular function, the contraction of the ejection fraction is normal, or it may be above the normal limits. And these are called the heart failure with preserved ejection fraction. And it has been postulated that they lead to a decrease in the epicardial fat, which helps the heart to relax better. And there's also a decrease in the atrial enlargement that leads to improvement of the cardiac output. It has got some mechanisms to help in heart failure with reduced ejection fraction by decreasing the adverse left ventricular remodeling. Cardiac inflammation is reduced, and some of the other pathophysiological mechanisms like increased glucose, myocardial glucose metabolism, cardiomyocyte, apoptosis, and so on. So on a whole, they help in decreasing the hospitalization for heart failures. We'll just look at a few studies for these as well. So now what you see here on the slide, these are not all, but some of the studies that have been done with GLP-1 receptor agonist in diabetic patients to see whether they would benefit in patients of established cardiovascular disease or if they have got risk for cardiovascular disease. So as you can see on the top part of the slides, these studies from Harmony up to Pioneer 6, they have actually shown that GLP-1 receptor agonists are superior to placebo in terms of reducing the 3-point MACE, which includes the myocardial infarction, stroke, and cardiovascular death. Two studies which are listed at the bottom, which is the Alexa and Excel study, they have actually shown non-inferiority to placebo in terms of cardiovascular benefits. So I'm going to discuss just a couple of studies here in the interest of time. So Sustain 6 and Pioneer 6 studies, which I'll discuss in the next couple of slides. So the Sustain 6 study is basically was done with semaglutide, injectable semaglutide, which is given once weekly. And about 3,097 patients were studied from 20 countries. They were diabetic with the average HbA1c of 8.7%. Average age was 64, and they were all obese, 92 plus minus 20 kgs. So they had high BMI, and follow-up was 2.1 years. And what they were looking at, the 3-point MACE, basically looking at the cardiovascular disease, cardiovascular risk factors, or CKD. And as you can see here, this is again a snapshot of the final results. So Sustain 6 basically was looking at the 3-point MACE, which was cardiovascular death, non-fatal MI, non-fatal stroke. This was the primary outcome. And they were also looking at which group reduced more weight, reduced more HbA1c, and systolic blood pressure. So as you compare semaglutide injectable versus placebo, you can see here that the events, which is the 3-point MACE, cardiovascular death, myocardial infarction, and non-fatal stroke, were less in semaglutide group compared to the placebo, and likewise the weight, HbA1c, and systolic blood pressure was reduced more in semaglutide group compared to placebo. Now let's look at the results more closely with this Kaplan-Meier curve, and as you'll see, the primary outcome, which was the composite of myocardial infarction, stroke, and myocardial death or cardiovascular death. This was definitely better in semaglutide compared to placebo. And there was a 26% relative risk reduction in reaching the primary composite outcome. And it did show a non-inferiority where you see the p-value was highly statistically significant of less than 0.001 for non-inferiority. And it also showed a a p-value which was significant for superiority. So it showed superiority as well as non-inferiority, and both were statistically significant when we considered the primary outcome, which was the 3-point MACE. And this was mainly driven by non-fatal strokes. Non-fatal stroke, as you can see here, favored semaglutide compared to placebo. And once again, the p-value was statistically significant. But looking at the myocardial infarction here, and as you can see here, that this was not statistically significant. Sorry. And certainly death from cardiovascular disease was also not statistically significant. Now let's move on to the oral semaglutide. Oral semaglutide, again, as you all know, has been introduced recently. This does provide some convenience to the patient that they avoid the injections of semaglutide, and it is very handy. It is taken in a dose which starts at 3 milligram for 4 weeks, and then you can up titrate to 7 milligram and then go up to 14 milligram, which is the highest dose. Has to be taken empty stomach, half an hour, nothing to eat or drink. Sorry, you can take just a glass of water and nothing else. So the question again was, do these medications also improve the cardiovascular outcome? So the trial that was done to look at or answer this question was Pioneer 6, to look at the cardiovascular safety of oral semaglutide in patients with type 2 diabetes mellitus. So design was again very simple. More than 3,000 patients were enrolled, and they were divided into 2 groups or 2 arms. One arm to receive oral semaglutide, 14 milligram plus standard of care, and the other arm received placebo plus standard of care. And these patients, the inclusion criteria was they have had to have type 2 diabetes mellitus. If they were above the age of 50, then they should have clinical evidence of established cardiovascular disease. And if they were above 60 years of age, then they ought to have cardiovascular risk factors only. And looking at the results, there were lesser events in patients who received oral semaglutide compared to placebo. And if you look at the p-value here, so this was statistically significant for non-inferiority, but it did not show statistical significance for superiority. That means it was non-inferior to placebo, but it was not superior to placebo in terms of reducing the 3-point MACE, which was myocardial infarction, stroke, or cardiovascular death. And if you look at the individual components of the 3-point MACE, so cardiovascular death, again, you will see it favored oral semaglutide. There were less number of events in oral semaglutide compared to placebo. And looking at the non-fatal stroke, they were almost similar. But unfortunately, the first non-fatal MI, as you follow the curve, the non-fatal MI seemed to be a little bit higher in patients who received oral semaglutide. And the hazard ratio obviously is more than 1 here. So did not favor semaglutide, rather it went against it. So the next trial I'm going to discuss here is the SURPASS trial. This is the SURPASS cardiovascular outcome trial. And the SURPASS cardiovascular outcome trial, there are 1, 2, 3, 4, 5. So 1 was done in 2022, and 2 and 3 in 23, and 4 in 23. And the first one, the results were published only last year. Now they have pooled all the SURPASS trial, uh, uh, the results, and they have also pulled the comparators, and they have put it in kind of a meta-analysis to look at the 4-point MACE and 3-point MACE, and to look at which favored Tirzepatide and which favored the comparator. So this is actually a pooled study from SURPASS 5. And as you can see, there was benefit in composite MACE, 4-point MACE, in terms of cardiovascular death, myocardial infarction, stroke, hospitalization for unstable angina, all in favor of Tirzepatide. Likewise, 3-point MACE, all in favor of Tirzepatide compared to the comparator. But unfortunately, the statistical significance was not met for superiority. So now this is another trial, which is the SURPASS cardiovascular outcome trial. Now this is not against placebo. This is Tirzepatide is compared here directly against Duraglutide. And so this was a trial looking at, again, the primary composite outcome was 3-point MACE, cardiovascular death, MI, and stroke, done in patients, more than 13,000 patients who were diabetic with HbA1c, mean HbA1c of 8.4, and they were all obese, average BMI of more than 32.6, and diabetes duration, this was a long diabetes duration, more than 14 years, and they were divided into two arms to receive tirzepatide or duraglutide. And this trial was followed up for at least 4 years. Sorry. So sorry, the result is here itself. So as you'll see there is a less number of MACE-3, cardiovascular death, MI, and stroke in the group who received tirzepatide compared to duraglutide. And so again, once again, if you'll see that it reached statistical significance for non-inferiority, but did not reach statistical significance for superiority. So again, it shows that it is non-inferior to tirzepatide is non-inferior to duraglutide, but it is not superior in terms of reaching the 3-point MACE. Now, this is a relatively new study. It has been recently published. This is Surmount 5. And basically, it is comparing tirzepatide with semaglutide. And these patients are not diabetic. They are all obese patients. And the whole point is to see which one fares better in terms of weight loss. And as you can see here, tirzepatide is far way better in terms of reducing weight compared to semaglutide. Now let's look at few slides only. GLP-1 agonists in heart failure. Now semaglutide has been studied in heart failure with preserved ejection fraction and obesity. And here, semaglutide in high doses used, which is 2.4 milligram. And this, as you all know, the semaglutide comes by the name of trade name of Wegovy. So this is 2.4 grams of semaglutide has been used, and the result was published in New England Journal of Medicine, and that has shown, and the conclusion drawn is that it does lead to reduction in symptoms and physical limitations, greater improvements in exercise function, and greater weight loss than placebo. So this was the trial. This is the STEP-HF preserved ejection fraction trial, and where semaglutide treatment has been studied to see in patients with obesity and heart failure with preserved ejection fraction. So question was, what is the impact of semaglutide on obese patients with heart failure with preserved ejection fraction? So there were some primary outcomes and there were some secondary outcomes. And clearly it has shown that this medication compared to placebo, it does improve the symptoms of heart failure. It does improve the quality of life that is assessed by the Kansas City questionnaire, and it also improves their functional capacity and the symptoms, and it also leads to improvement in weight loss. And mind you, these were not the patients with diabetes, they were just obese patients who had heart failure. And there were some secondary outcomes as well in terms of reduction of urgent hospitalization for heart failure, and also change in 6-minute walk and percentage of NT-proBNP, which is a marker of heart failure. They all favored semaglutide compared to placebo. And these are again what I have already said, that the change in the functional score, which is assessed by the KCCQ scoring, 7.8 difference in favor of semaglutide compared to placebo. And change in body weight, there was a 15% reduction in body weight compared to placebo with high dose of semaglutide compared to placebo. Now, Summit trial was done again in heart failure with preserved ejection fraction using tirzepatide this time, not semaglutide, tirzepatide. And total number of patients studied were about 731 from 129 centers around 9 countries. And here they once again included patients who were obese, mean BMI of 38, with heart failure with preserved ejection fraction. And the study was again designed to compare Tirzepatide against placebo, and the primary endpoint was very similar. They were looking at the fewer worsening in heart failure events in Tirzepatide group, and they were looking at also whether they led to any cardiovascular death or not. And the conclusion that was drawn that Tirzepatide reduced the risk of cardiovascular death or worsening of heart failure and improvement in health status of patients with heart failure with preserved ejection fraction with obesity. So it did show, went a step forward and did show some cardiovascular benefit, but there was no major difference in cardiovascular death. So if you combine the heart failure hospitalization and the cardiovascular events, then yes, there was superiority. Sorry, not superiority, I would say there was benefit, but there was no difference in cardiovascular death. So it didn't improve actually cardiovascular death. Now, how about the GLP-1 agonists in patients of heart failure with reduced ejection fraction? So we discussed a few studies, heart failure with preserved ejection fraction, but the other question is there any role of GLP-1 agonists when it comes to better outcome in patients of heart failure with reduced ejection fraction? So this was studied by Excel trial, and this was a meta-analysis of FIGHT and Excel trial, and this showed that there was more adverse outcome with patients who were on GLP-1 agonists. So there were more risk for heart failure hospitalization as well as the cardiovascular death. They were higher in patients who were on GLP-1 agonists. So it was concluded that GLP-1 receptor agonists may increase the risk for heart failure hospitalization in patients with heart failure with reduced ejection fraction, where ejection fraction is less than 40%. And then it was also stated that until then, the use of GLP-1 receptor agonists should be avoided in patients with reduced ejection fraction. Now, more recently, this is a praise heart failure reduced ejection fraction. I wouldn't say this is a trial. My apologies. This is actually a study. It's not a trial. And the key findings were that the study proved that a GLP-1 receptor agonist in diabetes management does not increase the risk of all-cause mortality for heart failure hospitalization. So this was a positive outcome seen, but this was again an observational study. It was not a trial. So what we really need is more and more randomized controlled trials with GLP-1 agonists to see if they really have a positive cardiovascular outcome in these patients with heart failure with reduced ejection fraction. So with that, I end here. Thank you very much for listening. And if there are any questions, I'm happy to take. Thank you.